Okay, now, in the interest of full disclosure, this is a bit of a setup. I was not involved with it, for the record. Had nothing to do with it. But this is Dr. Cassandra Quave, who is a postdoc in my laboratory. And she and I share an interest in what she asked about. So,
will you repeat the question?
She was asking about alternative strategies to our conventional current antibiotic practices, developing antimicrobial agents that focus on different targets than those that we focused on in the past. So it's a little bit of a complicated answer, so bear with me here. But I happen to be one of those people that firmly believes that bacteria don't care about you. I really don't think they do. I don't think that they have any interest in making you sick. I think that what happens, and as Dr. Sacente mentioned, we do in fact have, again, in a healthy human adult, it's about a factor of 10, even in an individual, of more bacterial cells than mammalian cells, our own cells. So we clearly are, and that defines a state of health, by the way. So we clearly are in a balance with these bacteria. And I was asked on the radio show to sort of define infectious disease, and the way I would define it is that balance has been disrupted. Now, there are two ways to restore the balance. I mean, there are two players in the equation. There's them and there's us. So there are two ways to restore it. You can either prop us up, which has been used successfully in, for instance, vaccination, or you can suppress them. And the conventional wisdom with respect to suppression is what we currently know as an antibiotic. And what these do, there are various classes and many different ones. Resistance to all of them is recognized and spreading. But what they do is they target attributes of the bacterial cell that are unique to the bacterial cell. The obvious idea there being to suppress them without toxic side effects. We also develop what are called broad-spectrum antibiotics, and the idea there addresses what Dr. Sacente noted with practicing defensive medicine and the problem of diagnosis. I mean, it's very difficult to get in a real time frame, certainly in the length of an office visit, but actually to get to a definitive diagnosis and assessment of resistance, I think is fair to say is measured in days. That's days while this patient is sick. So we use drugs that, not we, again, I shouldn't speak as if I don't prescribe anything, for the record. But that's why we've had this tendency in the last few decades to develop and use broad-spectrum antibiotics. Now, I just don't agree with that theory. I think that the reason we're here is because we're seeing the adverse consequence of that. We're seeing the emergence of resistance, so that now there are people in dire medical circumstances who could be saved, who cannot be saved, because the antibiotics that used to work don't work. All these factors that we're talking about contribute to that. Returning to my theme that bacteria don't care about you, I think when, for instance, Staph aureus finds itself, it normally is living in your nose and on your skin, and it's not causing a problem. But then something happens. Something changes in you. We mentioned my research focus on orthopedic implants. Isn't that a wonderful thing, that you can restore mobility with a metallic implant? But what that does is create opportunity. An opportunity, it creates an imbalance. And the staphylococci, through no fault of their own, find themselves in your bloodstream, and then they travel around. And all they're trying to do is survive. They just don't want to be killed. I personally can't hold that against them. Their efforts to survive is what leads to the disease process. It's what leads to the definition of disease. It's what leads to the pathology. So I'm of the opinion that if we can understand what they're doing, then we can develop a completely novel approach to infectious disease, where we don't just sort of throw the pharmacy at the problem, but we, in a very precise, think of it as a strategic intervention, in a very precise way, we would, for instance, stop Staph aureus from doing what it's trying to do. Again, not with any malintent, but just an attempt to survive. Cassie mentioned biofilms, and I don't think I used that term when I was talking about orthopedic implants, but it's that process of these bacteria colonizing these implants that leads to the formation of what's called a biofilm, which is just a multi-layered colony of bacteria that exist on this implant. We think that's what leads to the intrinsic resistance that we talked about. We think that's why those infections are so remarkably hard to treat. In my career here, I've known of, and I'm sure that there are far more that I don't know of, but I've known of 2 patients that elected amputation. And I remember the first time I heard that, I was recruited here by the chair of orthopedic surgery, and the first time I heard that there was such a thing as a patient who went into their physician's office because of these recurrent infections that couldn't be treated and said, "Doc, would you please cut my leg off?" I mean, think about that for a minute. That's when I decided that perhaps this is something that warrants my attention. So we spend a lot of time trying to understand what Cassie referred to as the virulence factors, or the factors that allow staph to accomplish. I don't even like to use the word accomplish because I don't think they're trying to make you sick, but they result in staph achieving that status that becomes a problem for the ID physician. Some people refer to this as pathogen-specific therapy. And frankly, pathogen-specific therapy at present is not economically viable. The reality is, I think it's fair to say that much of our medical care system is driven by economics. One thing you get out of broad-spectrum antibiotic is more patients. If you can use it to treat more infections, then you have a larger patient base. And I think the reality is that that has an impact. Unfortunately, right now, a lot of pharmaceutical companies are getting out of the antibiotic business. If you really want to be cynical, and I'll leave it to you to decide if I am, where would you rather put your money when it costs so much to develop any drug? Would you rather put your money in development of an antibiotic that a patient will take for a week, or development, think about what you see on TV every night, development of a drug, an antidepressant that a patient will take for the rest of their life? I think that there's a real economic, and until we overcome that, we're going to have a hard time doing what I'm suggesting. But I honestly think that we're starting to get to that point where the loss of life and limb will start to justify that approach.